you going to record the session?
Okay. Yeah, I've got it going. Okay. Let's do this first. All right, there you should be seeing my screen shortly.
Yep.
Okay, so this is you see a chest radiograph. So this is a young man who came in with fever, shortness of breath, chest pain, and had this chest radiograph. And you can see the hypoinflation, some opacities in the lung bases, and a lot of abnormal looking mediastinum. Hard to tell what's going on, if it's just a bunch of fat or something abnormal. But so he got a CT looking for causes of this pain. And you can see on the CT here that there's this stranding in the prevascular mediastinum. And then interestingly, in this subcarinal space, you've got this calcified lymph node with gas in it. And then in the medial basal right lower lobe, there's some consolidation, maybe, or at least some thickening soft tissue in that region. So the little pleural effusion here. So some sort of mediastinitis or something. It was unclear what was going on, whether there was a lung infection that had seeded this. Is this tuberculosis? But there's no real discrete collection out of here, but just the stranding. And so ultimately, he ended up having sort of an anterior sternotomy to look what's going on, and they just saw purulent secretions and a bunch of stuff in there, but no drainable collection. And it's most of the organisms are sort of just like polymicrobial flora, like you might see from an aspiration or something. So it's really unclear. Everyone's kind of puzzled what the cause of this is. If this is spontaneous pneumomediastinitis, or if he had a microperf of his esophagus, but it doesn't look like that. Esophagram done somewhere was normal. If he had a little lung infection that seeded the mediastinum or what. So we don't know what it is, but it's just very odd. I don't think I've seen an acute mediastinitis that didn't come from either above or an esophageal issue or seeded from below.
Jeff, what is that white stuff near the esophagus?
It is calcium in a lymph node that looks like old histo, and he has findings of old histo. He's got a dominant nodule in his middle lobe, and it's some draining lymph nodes in that vicinity. So that's what we think it is. It's just a super infected lymph node. Nothing in the spleen.
Not reactivation of histo or anything like that.
I mean, it could be. It's very rare. He's not immune suppressed, so and they did find just a bunch.
What's that dot of gas in it?
Yeah, that's what the striking thing is that's why we presumably got super infected. It's almost like a lymphadenitis on a background of
I was going to say, it's almost like it's a cardiac bronchus or something, but you don't see the communication with the...
No, and they didn't. I think they bronched him and didn't see anything either.
Huh.
So, yeah, it's just odd. The infectious disease folks were just kind of stumped what the source is, but I don't know if you never know if there was a microperf of the esophagus, but usually the esophagus gets pretty angry when there's problems with it.
Did they do an esophagram?
Yeah, they did elsewhere, and it was normal. Or I should say it showed a little dysmotility, but it did not show a leak or a mass or anything like that. So I don't know. It was kind of an interesting, unusual case. But yeah, when I see gas in the lymph node, you always worry about a fistula or something. Okay, this is a little bit more interesting case. So this is a patient who is about, at the time of this, was about 6 months out from a lung transplant, double lung for CF, and developed some lymphadenopathy here, and concern was for PTLD. Had a CT scan that indeed confirms this lymphadenopathy, kind of confluent. And then there was this little abnormality at the anastomosis, but just looks like maybe some little tissue there. There's the clip there. So underwent then biopsy of this and ended up getting Pseudomonas. So it was a very aggressive Pseudomonas. So they then decided to go in and operatively clean this. So this was a MR angio done beforehand, and you can see there's all the lymph nodes, and this is lots of T2 signal, and there was quite a bit of enhancement on these as well, sort of showing the central necrosis. And because it was a very resistant organism and probably was colonized pre-transplant or something, they went in and they actually did a repair and resected all this, and they found a very small dehiscence, which is probably where that little bit of tissue was on the CT at that area right in there. It's probably just some inflammatory tissue there, but there was a small dehiscence there. So they resected all that and then covered it, put a stent through there like this. But yeah, it's kind of an interesting case. So an aggressive Pseudomonas causing lymphadenitis, presumably seeded from the small, or was in the airway colonization, caused a small dehiscence and then seeded the surrounding lymph nodes.
Wow. That is remarkable.
Yeah, that was an interesting one. Okay, and then I have two little companion cases here. So this is this was a case that was done. Young man, early 40s, presents with chest pain to the emergency department. So and had some EKG abnormalities. So they we don't do too many of these, but they opted to do a coronary CT on him, and this is the calcium score, and you can see there's a fleck of calcium at the root, but you don't see any coronary calcium. He's got healthy looking vessels at this point. But on the angiogram pictures, you can see.
Do you want to? Oh.
You can see right in the proximal LAD, there's a little defect here. And then in the mid RCA, there's actually quite a high grade stenosis, or it looks like a high grade stenosis. It's all soft tissue and it's kind of circumferential. And then it kind of goes back to normal. And here's just the 3D, but you can see that stenosis there. So interesting, he ended up having a cath that didn't show any significant stenosis at this area, and was and had an echo that was normal, so was discharged on medical management. So one of the things we're doing here, we're starting to do selectively is fractional flow reserve, and I will show a case. So it's possible that this case may have saved an admission and a cath by doing FFR. So here's another case. This is a patient in his 50s, similar presentation. I'm going to have to stop for a minute. Can you just, I'm going to turn it over to Howard just for a second. I can come back to this if there's time.
Okay.
I'm doing a phone call now, so okay. Yeah.
Oh, sorry. Okay, Howard, I'm sorry. Wait, phone ringing off the hook. Okay, so you can see that he does have calcium in his proximal coronaries and some aortic valve stuff.
Perfect.
Here?
Hold on, I'm going to mute these people here. There we go. All right, and so we did the coronary CT, and you can see there is there's plaque, and there's flow, and there's some narrowing of the RCA. And if I go down to the distal LAD, you can see it's patent. It's pretty small, but there's more upstream plaque. And then these are the FFR images here, just to show you it's anything greater than 0.8 is good flow. And the lesion in question, the distal LAD, was 0.82, so just above the sort of the threshold, but everywhere else had good flow. So this was just a discharge with medical management. So potential to use this as sort of a triage tool to avoid going to cath.
Can I make a quick comment?
Absolutely.
So we do this quite frequently, and you have to be very careful about assessing these results because the FFR numbers are only valid across the stenosis. Mm-hmm. So you're not supposed to, like in a distal vessel, you're always going to get a trail off of FFR. Correct. But if there's, like in that lesion there was nothing to cause that drop. It just normally decreases as you get distally. Mm-hmm. So I've had people that reading it and saying, cardiologists who are looking at it saying, oh, this is positive because it's 0.7 at the distal vessel, but there's no stenosis. And you're like, that's not how you read them. So there really has to be, it's the gradient across the stenosis is not. Anyways, there's papers on that and stuff.
Okay. Yeah, and you can see in these images how it sort of slowly drops as you go more distal. So yeah, I think it's coming along, but we're doing more of it and getting more experience with it. Okay, I'm going to turn it over to Howard now, and let me see if I can do that. Do that, and then there we go. That's all you, Howard.
Okay. Can you guys see my screen?
Yes.
Okay. Let me just see this one. This is a nice example of spontaneous waning of opacities in a patient that's known to have CVID. And let's see if I can find this. So this is one example from May of 2016. In terms of what these opacities look like, they're certainly quite consistent if you have a patient with known CVID with GL-ILD, granulomatous lymphocytic interstitial lung disease. I think one can make a fairly confident diagnosis of that. They're focal, multi-lobar, various sizes and shapes. Some of the lesions have patent airways going through them, but in terms of suggesting a diagnosis, I would be very comfortable ascribing opacities like this to GL-ILD. And let's see if I'm right, because this person had a follow-up without treatment. So that was, sorry about that, I'll bring it up. That was May. And you'll see these clear up within a short period of time in the absence of any treatment for it. I don't know whether he's on IVIG, but there was no indication that he was treated for an infection. So the phenomenon of waxing and waning of GL-ILD is a known thing. Of course, one doesn't know what really goes away, are the little granulomas, the cellular granulomas, or the foci of, say, lymphocytic interstitial pneumonitis. But I've seen a spontaneous waxing and waning phenomenon in this quite a few times. And when the lesions are large, the clinicians get nervous. I think this is a nice example, presumed, of spontaneous waning of lesions of GL-ILD here in just about 2 months or so, just over 2 months. And this is just plain old anatomy. Someone the other day was asking me what a certain interface was, so we were teaching just basically anatomy. So this is a situation that is not common, but it's not rare. And it's a situation where, and I'll go right to the area of interest, where one can teach about the anterior or the posterior junction line being up here. But this is the interface that's interesting. So this isn't a common interface, but it's a situation where lung, in this case, the right upper lobe, abuts the lateral margin of the aorta. And of course, usually that doesn't happen because there's so many tissues and items that prevent the lung from touching the aorta here. Fat, SVC, right atrial appendage, and so on and so forth. But this I'm pretty confident, and I've seen this before. Sometimes if you have a lateral and you look in the retrosternal region, you'll see there's quite a bit of lung there. But this is just an anatomic interface where randomly the right upper lobe abuts a portion of the ascending aorta, its right lateral aspect, and is entirely normal anatomy. So just a nice example of that. This is kind of interesting. This is basically just physics. So just like I'm sure you guys get a lot of cases to overread, or you get comparison examinations for interstitial lung disease from outside institutions, and you're comparing a bunch of different studies. If you get an exam that looks like this from an outside institution, I would say this is a great example of using a reconstruction kernel that is simply too great. So it's a high spatial frequency algorithm. And here they've chosen, and I can show you this pretty easily, but this is way too high. This is a Siemens unit. And this one, if you go down to the kernel, you'll see that it's B80S. We never use more than 70, and sometimes I even think the 70 number, which is the strength of the kernel, is sometimes perhaps a little bit excessive. But I think when you get this, of course you can see the reticulation, but I think being able to see what is reticulation, what is potentially air-containing bronchi, traction, bronchiolectasis can be really hard. Maybe there are larger cystic spaces there, but I think it's a very nice example of using too high a number, too high a strength of the spatial frequency algorithm. What do you guys think? Do you see this? I'm sure you probably see this.
Absolutely. Agree, Howard.
This-
And we see it with the GE scanners where they use the lung kernel, which is designed for thicker cuts, not thin section. And,
yeah, combination of
yeah, unfortunately, the naming convention is sort of a problem. But yeah, I've seen this with the Siemens one too. I agree, 70's even a little high for me.
Yeah, it's a nice example of an inappropriate kernel. This one is just a nice follow-up of a patient that has a diagnosis of coccidioidomycosis. So there's nothing particular about this right upper lobe opacity except that a transbronchial biopsy yielded coccidioidomycosis as a diagnosis. And I don't know if that was a surprise or not. And certainly what will happen over time is a little bit unpredictable, but this shows a nice evolution of, let me see if I can fix that, bring that up there. Sometimes these will clear entirely. Sometimes the focal opacities will cavitate and leave a cystic spaces with a relatively thin wall. This one is, and here's the time interval. This patient was treated and apparently is doing just fine, where the overall size of the lesion is clearly diminished, but there's still a little bit of liquefaction and a little bit of cavitation in the middle of this. So I don't know what to make of that. I have seen that before, and I think the patient's doing fine. I think they just need not worry about that. Maybe it'll cavitate more over time. I don't really know what happens, but I've seen that phenomenon before where it doesn't go away. And I presume you guys agree that if the patient's doing fine, just continue the therapy.
Yeah, we see cocci that stays around for years and is unchanged.
Yeah, that's what I was thinking. It was just one of those. Okay. This one is a very interesting case from several points of view. This patient came to us after being treated for quite some time at an outside institution. So the story begins quite a long time ago when basically the background is recurrent pneumonias. And every time, as best I can tell, she had a pneumonia, they treated her for a pneumonia. And I guess she got better, but kept on having pneumonias. And if you look at this image, you'll see there's a substantial amount of abnormality in the right upper lobe. So we have a lot of material in the lumens of bronchi. We have airway-centric opacities. But of course, we also have that. And I don't know if that was not really perceived as a thing in that right main bronchus. But she just kept on being treated for pneumonia. So I'll show you a couple images. Here's one from November of 2018. And here's one from later on that month. But then you have this phenomenon where in February there's less opacity there, but there's still some abnormality there. And then here is an image from March of this year. And you can see there's more opacity. Perhaps some of it represents intraluminal material in the lumens of dilated bronchi. I think it does. And then most recently, we have this, which shows extensive abnormalities. So now we have findings for sure of substantial obstructive right upper lobe atelectasis. And then an unanticipated finding I will show you here is, in the absence of any intervention that we know of, is a pneumothorax. So here's a pleural line, and I'll show you a CT in a moment, but there's a pleural line. So there is a pneumothorax at this time. and certainly very consistent with the entity of pneumothorax ex vacuo in the context of obstructive right upper lobe atelectasis. So here you'll see extensive abnormality. You'll see the pneumothorax. I guess there's some adhesions traversing the pleural space. Here is the tumor that's growing, and this is confirmed. So delayed diagnosis of a large central tumor that ultimately presented with pneumothorax ex vacuo. So that doesn't need a chest tube. It's just something that can happen with obstructive atelectasis. I think it's the largest one that I've seen. And then otherwise,
what's the mechanism for the ex vacuo phenomenon?
I don't know if anyone knows for sure. I think it's maybe the notion that the lung wants to collapse and does to some extent, but for some reason, presumably nitrogen is drawn out of the tissues into the pleural space somehow and accumulates about the collapsed lobe. But the classic description was from the Journal of Thoracic Imaging, describing obstructive atelectasis with pneumothorax ex vacuo. So I'm not quite sure exactly why that happens. But that's, I think, undoubtedly what that is. So I'll send along that classic article from the JTI describing, and they described a couple of cases of that. And I think, oh, I'll show you this one real fast. So this is an interesting case in this sense. This patient had a CTPA for PE. There's no PE, but there are a bunch of findings here, very typical of sarcoidosis. So there's scattered nodules in the lungs, a few of them. So for example, here, and there were a couple more in a few places like there. There is a fair amount of nodal tissue, so enlarged hilar, infrahilar, and mediastinal lymph nodes, not particularly big. But this I want to show you is a really nice example. Let me bring up the coronal of the involvement of intrapulmonary lymphoid tissue in relation to relatively small vessels and bronchovascular bundles. And some of them actually, if you scroll through fast, I'll show you a couple, may initially look like pulmonary emboli. So let me just go and find a couple that I saw. So for example, here, right there, and I'll show you a few more, right there. And there are going to be a few more nice ones, like right there. So let me mag that up, right there. And right here. So there are a couple places in which I'm pretty confident we have involvement of intrapulmonary lymphoid tissue near perhaps branch points of bronchovascular bundles, like right there. It's kind of a case where the more you look, the more you see. But I think I've seen that before with sarcoidosis, where presumably just lymphoid tissue is expanded by granulomas, like right there, for example. I'll just make that one up. Do you guys agree? Do you see that occasionally? Like that?
I don't think I've ever seen it so far peripheral, but maybe I need to start looking.
Yeah, this is not common. I've seen it on occasion. Like here's one here. See that there? And there are a couple places. Look here, for example, right between the vessels, and there. They definitely are not in the vessels, but just adjacent to it. There's a lung window. Doesn't help that much. I see that occasionally, and I think I see it in sarcoidosis when I do see it. Right there. All right, those are my cases. Let me go to the controls. Who would like to go next?
I've got a few.
Okay.
I can go after.
Okay. So we'll start with David, and then we'll do Seth. There we go.
So this is a woman can people see a röntgenogram here with a port catheter? Okay. This woman had had a stem cell transplant a couple of years before for AML, and she has this inspiratory CT, which shows this patchy ground glass abnormality, but the black parts of the lung have pretty sparse vessels in them, so maybe the ground glass lung is good lung here and not bad lung. And then she had expiration as part of this. Sorry, that was the expiration. This is the inspiration, which shows the ground glass abnormality already, which the expiration, which I showed you first, actually just makes more pronounced. So on expiration, the blacker areas of the lung do not fill in. They do not achieve the higher lung density that would be expected if air went out of those areas. So it's really all profound air trapping. So this one has really a pretty severe case of bronchiolitis obliterans syndrome, or really constrictive bronchiolitis from graft versus host disease. So this is more dramatic cases of this condition. Generally, in stem cell transplantation, the degree of constrictive bronchiolitis is not as impressive as it is after lung transplantation. But here's a case where it's pretty dramatic. Okay.
Yeah, so that's really just hyperemia, right? It's not ground glass per se, because it's normal lung. That's just overperfused because the
right. That's getting all the blood that should be going more uniformly to the lung, but it's being concentrated in areas. So you're right. And
it's interesting. I've seen this degree of hyperemia in CTEPH or whatever, CTEPH all the time, but not in BO. I have to say I haven't seen this degree in obliterative bronchiolitis before. I see it all the time in the CTEPH cases.
And this persists today. So this scan was back in 2007, and her current imaging shows about the same, pseudo ground glass abnormality, or the same mosaic attenuation. It's just that in order to find an expiratory series, I had to go back to 2007, but her current imaging looks pretty much the same. So a dramatic case of BOS. So this person has a mediastinal mass. I always propose immediate biopsy in these cases, but they got a lateral view before biopsy here, and you can see that there's an impression on the back of the airway. So the supposition was that this was a right aortic arch with aberrant subclavian artery. And the CT scan was performed, and indeed we do have a right aortic arch. It's a non-contrast CT, but the abnormality on the left that is causing the convexity, the mediastinal convexity, is actually a left aortic arch. And so I thought this is going to be another one of our double aortic arch with a atretic segment, except that there is no atresia back here. So this is actually a continuous double aortic arch, and it is encroaching on the airway, and it's dragging, because there's a left moiety here, the descending aorta is being dragged toward the midline to connect with this. And I think that the telling finding on the coronal is the V-shaped origin of these two moieties, the right and the left moiety. So you get this V-shaped thing here. It actually looks like a thumb on a glove. The right arch being larger and going higher, but the left coming off the front here. So the resident looking at this, was still going with aberrant subclavian and all that kind of thing. But or is talking about mirror image branching for a while and things like that. A lot of confusion there. But if this is really a right aortic arch that's not part of a double arch, then you don't get this V-shaped origin. You get this the left moiety coming off the top of the right aortic arch, not off the side like this and forming a V. So this is V for victory here. This tells you, I think, pretty reliably that this is a double aortic arch. And then you can see, if we go back to cross sections here, we don't have the world's best symmetry of the four vessels, the four brachiocephalic vessels in the upper mediastinum and lower neck, but it's reasonable. It's symmetry with a little bit of a tilt. So double aortic arch and a vascular ring in this person. Now, my notion is that double aortic arch is pretty uncommon, but I thought I picked up a conversation in the reading room implying that it was more common than right aortic arch with aberrant subclavian or mirror image right aortic arch. What is the notion you guys have of the relative frequencies? I thought double arch was pretty uncommon.
Yeah, that's old literature, surgical literature based on cases going to surgery. And of course, the double arch is going to be more common because it's much more symptomatic. But now that we do CT imaging on everybody, I think I've seen 3 double aortic arches or 4 double aortic arches in 10 years, including all the congenital heart disease stuff I do. I mean, and we see right arches all the time that are asymptomatic. So I think that old literature is just wrong.
Okay, so my notion that double aortic arch is relatively uncommon still.
Yeah, I think they're extremely rare.
Yeah,
Okay,
I think it's, David, if I remember, I think it's like 1 in 10,000 versus 1 in 1,000.
But
Got
you're
it.
right. But if you look at the old literature, say the most common ring is a double aortic arch, which just, and that's
Most
old
common
surgical.
symptomatic ring.
Symptomatic ring, yeah.
Okay. So CT has changed everything. It's changed our appreciation of statistics. So I wanted to show you a diaphragm case. This fellow had a few different surgeries. One of the more recent ones was a drainage of a pericardial effusion with a pericardial window on the left. But I went back to older CT scans before that procedure, which was done, I think, sometime around the beginning of the year or so. And he already had this pleural process on the left here. So he came here. Let me show you what CT looks like for him. And this is after one of his recent surgeries. So at this point, he still has a pneumo component, not just a pleural effusion back here. And he does have pleural thickening too. You can see that there's a white stripe on both sides of the fluid collection. So hydropneumothorax here after a pericardial window placement and drains being in place and all of that sort of thing. But he's a little short of breath. And so they asked me to do a diaphragm fluoro on him. So I wanted to show you how you can restrict diaphragm motion from a pleural process. And it should not be mistaken for paralysis. It's diaphragm dysfunction, but it's really tethering by the pleural process. So I'll just go through the series here of deep inspirations. And so you can see that the right hemidiaphragm moves very, very nicely. It exceeds 1 rib interspace excursion, which I consider the lower limit of normal. Just, David, it goes past 1 rib, so more than 1 rib interspace excursion. But you can see that on the left here, looking through the heart, the medial part of the right hemidiaphragm is able to move, and the lateral part is tethered out here. So it's really operating from along a hinge. This pleural tethering out here gives us a hinge, and you can see why he has restrictive lung disease on the left here. It's this pleural process. So this is tethering. Let me go back to the CT to show you that cruise thickness was normal. There wasn't any sign of wasting of the cruises. As a matter of fact, if you've got tethering like this and restriction, you can actually hypertrophy your cruise by the muscle having to work against that resistance. So you see we have good muscle thickness here of these cruise bundles posteriorly. So we don't have atrophy here, but we have restriction, in this case caused by tethering. So I'm bringing this up because not all of our radiologists here were aware of this possibility, but this is why diffuse pleural thickening can cause restrictive lung disease, because you can basically tether your diaphragm. So he's scheduled to have decortication early next month. So they'll go in and try to free up that lung. So this is trapped lung with a pleural process and diaphragm restriction. Okay, those are in case I wanted to show.
Great. Great. Okay, Seth, there you go. Can't hear you, but we can see you.
Sorry, had the mute on. So this is an old school LVAD HeartMate 2, which fortunately they don't use anymore. A lot of problems with these, especially with some issues with the cannula placement and thrombus. Anyways, you can see here on this HeartMate 2 that the inflow cannula looks fine. Here you can see the device and the drive line, but then you can see in the outflow cannula, there is this very large chunk of thrombus in there, and which is not good for various reasons. One, not only is it slightly limit the purpose of the heart flow, which is to pull blood out of the LV and shove it into the aorta, but it also has a tendency to put that clot into bad places. So the patient first presented with decreasing flows on the monitors when they were assessing this device, and then I called them, and then they said, oh, she's not moving as well as she was. And then you can see here, she's starting to develop, and this is literally the same day, all these areas of stroke, and then you can see them progress. This is like 2 days later. So here now you can really see all of this embolic stroke. I mean, this is all just, and then she died. So bad outcome from a outflow cannula thrombus that embolized to the brain, causing massive stroke and death. So that's case 1. Case 2, I don't remember what this is. Let's see what the chest x-ray shows. Oh, this is a nice case. Only because that's a pretty case. I hadn't seen this in many years, at least not an example this nice. So chest x-ray is a chest x-ray. I mean, there's some peripheral areas of consolidation. Obviously, that changes your differential diagnosis. But beyond consolidation, there's architectural distortion. I mean, these are not new areas. There's scarring associated with it. And then I'll show you the CT, which I think is really one of the nicer examples of this I've seen. And you can see that these areas of consolidation, which are kind of having what I would call organizing pneumonia pattern, if you look at them, you can see that there are many areas that are high in attenuation, and multiple of these have areas of high attenuation. And then you can also see the liver is dense, not the most dense liver I've ever seen. But here again on the axils, you can see these areas of high attenuation. So this is amiodarone, chronic amiodarone toxicity in the lungs presenting with kind of organizing pneumonia, with high density kind of organizing pneumonia, and then the liver involvement. I just haven't seen that in many years. And he definitely is on amiodarone. Check that out. And what is this case? Oh, this is this was a new one to me. So a couple of months ago, I showed a case of a young kid who came in with Al-Kappa, who was, sadly enough, had gone through multiple not coronary interventions, but interventions for AFib. And then on a pre-planning AFib CT, they did we saw that the patient had Al-Kappa. Now, what's interesting about this case, in every case I've seen, especially those most of the repairs I've seen have been in younger patients. But the same issue, the surgeons obviously have the same issue no matter the age of the patient. The issue with them, so there's 2 ways to do the surgery. One is that the left main, which usually comes off the lateral aspect of the pulmonary artery, what they hope for is that they can just literally, it's long enough that they can just pull it over and attach it to the aorta. And that's their preferred method, because literally I had a surgeon tell me anyone can do that, even you could just cut a button here, you cut a button here, and you sew it on. But in some instances like this, the PA or the left main isn't long enough to connect from the left main here, is not long enough to pull. So they create, this is called a Takeuchi repair, where they literally create a pericardial baffle, and they put the pericardial baffle through the pulmonary artery. So it starts at the aorta, goes through the pulmonary artery, and then they create anastomosis with the pericardial baffle and the left main, which was attached to the PA here. So they literally create an intra-PA baffle using pericardium so that the aorta can flow into the left main. So it's just a type of Alcapa repair that I had not seen or heard of. Additionally, it's very interesting because he has all these subendocardial / papillary muscle calcifications from this chronic ischemia he had due to the Alcapa and the LAD distribution. And then last,
yeah, the channel goes through the pulmonary artery. Why not around it?
Because I think they leave the ostium to the pulmonary artery intact.
Got it. Okay. All right.
So they just literally put it in and then just sew it to the ostium of the PA, so they don't have to, because the ostium of the PA is too, because otherwise then they have to ligate this, go into the PA, ligate this, and it's just a repair technique that's I never heard of, but again, well documented as a treatment for these cases where it's not. It is clever. Let's see if this. Oh, the whole thing didn't download. That's unfortunate. Oh, that's a shame. Okay, I'll show it anyways. So this was a patient who had a very heavily calcified aorta and basically had this little gap here that wasn't too impressive. This was back in 2013. He had a non-contrast CT back then. You can see there's he had some form of type A dissection. You can see the graft material here with the repair, and then this very chronic looking dissection and a little hole there, which they didn't do anything with. And then he had a study just the other day. Unfortunately, I don't have it with, but it's mostly a chest X-ray finding, and I'll have to send it along, where this defect, where there's lack of calcification, here you can see better. There's just, the whole thing is heavily calcified, and on the next one, you can see that this defect has gotten larger with a larger kind of outpouching from the aorta. It's a really nice chest X-ray, and I happened to get lucky that day and pick it up and sent him for a CTA. And it's just an interesting CTA talking about this very calcified, chronically calcified false lumen. And it's kind of interesting to think about how these things occur with the intimal displacement anyways. And then here is that defect here. So that defect had gotten much larger, but they're not too concerned. They're just watching him. And even though this dissection is heavily calcified and quite old, that there's still a lot of filling. Even though the false lumen is predominantly thrombosed down here, there's still a lot of flow from above and below. But it's just a cute example of a chest X-ray finding, but I didn't have the chest X-ray, so not as pretty.
No, that's interesting.
I mean, that looks pretty dire. Don't you think that this is going to rupture?
Oh yeah, it is ruptured. I mean, it's out, but I guess he's not in great shape.
Okay.
And no, I'm always surprised about the things that I'm like, that's really bad. And they're like, yeah, we're just going to watch the guy. And and I found that from the surgeons in a lot of places, things that I'm like, this looks really bad. They're always like, yeah, it's not that bad. But on the chest X-ray I'll show you, you'll see the whole thing is just densely calcified. And then there's just this big gap, which is a good clue that this is there. Okay, those are my cases.
Odd. Good. Travis, you still there?
Yep.
Good. Hold on. All right. Here we go.
You see a scout from
Good.
the CT. Okay. So this is a patient at the VA who came in with cough and fever and has a left upper lobe pneumonia on the 31st of May. And you can see that finding is confirmed on the CT. He's got some junk in the airways, but nothing obstructing the airways. I got involved with this case yesterday. He came back in 2 nights ago and had this radiograph performed overnight. And so this has been, 3 weeks since that. You can see it's a curious change in appearance of his left hemithorax. And it doesn't look like there's an effusion because the diaphragm's elevated, because we still see gastric or colon under here, what looks like it's probably the diaphragm there. And it's curious, pneumonias can improve over the course of a few weeks. Maybe he re-aspirated, maybe there's some component of atelectasis here. But this was kind of done overnight, and I admittedly knew that he was getting a CT and didn't think too much of it. But here was the CT done yesterday, and instantly when I saw this CT, I realized what had happened. And we can see when you compare the CT, how there's still consolidation, and if you follow the airways, it's still the left upper lobe, but of course the left upper lobe is no longer where the left upper lobe belongs. And I'll show you the sagittal in a moment. And I will show you a companion case, because I had only read and remember seeing Jeff show a case of, what I suspected this to be, which is torsion from the pneumonia. And you can trace the airways here. This is the superior segment of the left lower lobe, which is now flipped up. And this is all portion of the left lower lobe that's coming anteriorly. So the major fissure has changed its orientation, and of course, explains why the radiograph looked the way it did. And you can see the swirling as we move across here, where the left upper lobe has now torsed anteriorly and down. So whatever, I guess that's a counterclockwise rotation when you're looking at it like this. And you can see the swirling both on the lung and the soft tissue windows. So spontaneous torsion secondary to pneumonia, just weighting down the lung and causing it to flip. And so what's interesting is that he was transferred to UCSF overnight and then operated on, and they detorsed him overnight. And you can see now that the pneumonia is back up in the left upper lobe as it was on the radiograph from a month ago. So it was only a partial or incomplete torsion. The vessels were still patent, so there wasn't complete ischemia or infarction of this lung. And you can see how on the axial, they do twist and attenuate a little, but the veins get pretty darn narrow there, but there's still some blood flow getting through this. So they were able to save the lung.
So, Travis, that aerated lung in the left base on CT is left lower lobe still, correct?
This is still part of the left lower lobe. So I don't know. Yep. I haven't been able to talk to the surgeon yet if there's a complete, if there was any sort of an inferior pulmonary ligament or not. I know they did do a pexy to the diaphragm and to the epicardial fat.
I think there is a ligament, and I think that's why you still have aerated lung there. Why they didn't basically, why the swirl didn't complete itself and the left upper lobe end up completely above the right. It was stuck by the ligament, remained in place back there posteriorly.
Yeah.
Seriously, like this is like the 5th case of torsion you've shown. Like why? I mean, am I missing it every day, or is it just more common in San Francisco? Like it's very.
I don't know. It's a good question.
There are more people in San Francisco, I think.
Yeah, they're very well.
So I went digging. This is Jeff's case that he showed, and this was a right lung. So this was right upper lobe pneumonia, and that was here. And then, a month later, they came back in, and their pneumonia was now in the right lower lobe, or in the right lower hemithorax. And so here's his, where you see it in the right upper lobe, and then on the follow-up CT. And I don't know if Jeff is still on or if he remembers if they went to detorse this or not. But in this case, it rotated like backwards rather than forwards, I think, because this is, in his case, the right middle lobe is in here, and it is what is now occupying the apical portions of the right hemithorax.
Mm-hmm. That makes sense.
So, but
and Travis, the interesting observation is these patients have nearly or totally complete fissures.
Yeah.
And that may provide extra mobility, at least on this case that you're showing. It looks like the fissure is pretty complete.
Yeah. Okay. So you are still on there listening.
I'm still here. Yeah. Our guy never had surgery or anything. It just was a spontaneous torsion after an infection.
And it's also been reported spontaneously with masses, with pleural effusions, pneumothoraces, something that allows the lung to rotate.
Yep. Wow.
So let's see. Now, this one came in last Thursday, right around the time that David, David did not help us set this up intentionally, but he did set it up. And this is courtesy of my colleague, Kim Kalianos, who was all over the diagnosis. This is a patient that came to us and had this radiograph. And there are a couple findings. He's 27. He has a left internal jugular central venous catheter. And you can see he's just got very busy lungs that look nodular. His pulmonary arteries may be a little big on here, but everything else was done outside. And the history was he was transferred to the ortho service here because of septic joint of some sort. And she found the outside study from a few weeks ago, and this was called miliary disease at an outside hospital. Of course, it's not miliary, it's centrilobular, and you can see how it spares the pleural surface, and they're very discrete little solid centrilobular nodules. The first thing we're going to look at is his pulmonary artery. His pulmonary artery is big. And the next thing, she went back and looked that last year, before he had a line, he had none of these. This was in 2018. So we called up the clinical team and rather matter-of-factly told them we think the patient's injecting. And the clinician said, well, that makes a lot of sense because he had infected lines but was refusing to have his line taken out. And for the obvious reasons that he was injecting crushed up tablets. And so they did find that he had syringes and crushed up oxycodone in his room that he was injecting. Mm-hmm. So it was another excipient lung case.
Yeah. Wow. And you make like a 5 millimeter MIP, I would say, something like that. In.
Yeah. Well, we can do that.
Yeah.
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 Oh, very nice.
And again, infection. Sorry, say that, David.
They're just beautifully centrilobular. They just float away from the external pleural surface.
Yeah.
Yeah.
And like we've made the point many times, whenever you see stuff that's this diffuse, unless it's actually miliary, but when it's this diffuse centrilobular, it's not infection in most cases. It's like some sort of either exposure through the airways, like a hypersensitivity pneumonitis, or it's something being injected.
Yeah. Right. It's also nice to teach lobular anatomy. So for example, if you find a pulmonary vein that doesn't have the branching opacities, you can actually show that the pulmonary vein is on both sides of a lobule, mm-hmm. and all the branching mm-hmm. lobular arteries are between the normal veins.
Yeah.
Sometimes if you just scroll back and forth for a while, you can pick that up really nicely.
Yeah, some of the veins in here
are not the branching structures, but it's the arteries, the lobular arteries that are. It's a nice way to teach lobular anatomy too.
Yeah.
Yeah, right there. This pass was beautiful.
And of course the fissures as well as the juxtapleural lung is spared too. It's harder to see that on MIPS just because you're slicing through the fissures, but. So yeah, perfect timing from that. And then let's see which one, and then this one I'll finish with. This is just a quick radiograph. And again, this was from Kim, who was on call this weekend and texted me this photo. This is a patient who came in, and the PA radiograph, I would argue, looks normal, but I'll give you a second, see what you see on the lateral.
Pneumomediastinum.
Yeah, exactly. Yeah. And I think this is, and it's really only the ring around the artery sign a little here and maybe a little bit along the aorta.
A little bit up higher, yeah.
And I think it's hard to tell if some of this is trachea or if it's just the scapulae overlying, but without a doubt. And it fit perfectly. They actually never did a CT, but the patient had severe coughing fits and had sudden onset of chest pain. And then the next day they repeated, and I'll show you the follow-up lateral, and the findings are gone, or maybe there's still minimal here along the aorta. But I think it's one of the better examples of the ring around the artery sign from the right pulmonary artery that I've ever seen. Yeah, so subtle finding, and the clinical team totally agreed with that. And so probably had alveolar rupture on the right, and it just tracked back into the right hilum.
Yeah. Now, if you just change the window width on the one on the right a little bit more, make it a broader window width.
Here on the lateral.
Yeah. If you look at the ring of air underneath the right pulmonary artery, which is there. Now, if you go up higher to the top of it, some of the air right there and a little bit above actually is air that's touching the superior pulmonary vein, which courses along the top of the pulmonary artery. So
you think that's probably superior pulmonary vein there?
Yeah, it's a combination of ring around the artery and a bit of a ring around the pulmonary vein, which obviously crosses the right pulmonary artery on its way to
probably a little along the ascending aorta here.
Yeah, that one's a little harder to see. Yeah.
I think so, though.
Pick up the anatomy.
Because you just see the ascending aorta too well, and then I don't know if this is this is probably just vessel rather than along the main pulmonary artery, but I don't know. So
very nice.
But a good eye test and a good pickup. So
very nice.
All right, well, it's 1 o'clock.
Thanks, everyone.
Right,
hey,
thanks, everyone.
real quick, can you show my screen real for 1 second, half a second? Quick. Sorry, let's see here. Just for the sake of completeness, here's what I was talking about with that other aorta. So you can see this, the most calcified aorta I think I've ever seen. And then the calcium just stops, and there's this little bit, which was much bigger, and that was the finding. But I'll send that. I'll send that along. But, okay, that's it. Thanks.
Thank you.
All right, thanks, guys.
Thank you.
Thanks, everyone.
See you next week.